Hi everyone, my name is Zach Hodges. I'm a pediatric hospitalist here at MCG, and I'm excited to have the opportunity to review the case with you today. Thanks Dan and Nicole for the opportunity. So on this week's case in MSK and skin, we will be reviewing a case of a 12-year-old boy who has the eventual diagnosis of juvenile idiopathic arthritis. So let's just jump right in. So our chief complaint is fever and generalized pain for 4 days. Jay Carter is a 12-year-old who's brought to the ED by his parents with fever and generalized pain. 5 days earlier, during a trip to Arizona, he had two skin lesions noted on his right antecubital fossa, what they thought were insect bites. No one else is sick. He awoke the next day with severe generalized aching musculoskeletal pain. It was most pronounced in his thighs, ankles, and lower back, and to a lesser extent the forearms and feet. Pain involved both muscles and joints, and it was 9 out of 10 in severity. No particular muscle or joint was worse than the others. There was no joint erythema or swelling. So later that morning, the pain was sufficiently better, and the family was able to continue their vacation, but it got worse each day, unresponsive to ibuprofen. And then he was seen in urgent care and referred to the emergency room, where he was found to have a temperature of 39.5. So associated symptoms including chills, nausea, vomiting, left lateral chest pain with inspiration, and some somnolence over the last couple of days. Denies usual or unusual strenuous new exercise or any history of injury. No recent URI symptoms, and nothing else on his review systems. So you'll notice some highlights and some notes that I've made to help me remember everything that I think is significant. First in pediatrics, looking at the fever, it's helpful if we can actually have a measured temperature. So many times our families will just comment on subjective fevers, but if a fever is measured and we actually record how it was measured, whether it be an oral temp or an axillary temp, can be really helpful. Another thought is how many days of fever. As fevers kind of progress past 4 and 5 days, the risk of an acute infectious cause becomes a little bit less likely, and then we start thinking about inflammatory causes being more likely. Looking more at the history, our patient has multiple sites and bilateral involvement, of different joint pain and muscle pain. To me, this suggests like a systemic cause and not really like an acute focal infectious cause. Moving on to his description of the pain and what made it better. So we have a particular trend here where he was hurting worse in the morning, but improved during the day. And this is really consistent with inflammatory causes of pain. What's also more helpful than pain on your history is kind of getting a sense of stiffness. Patients with juvenile idiopathic arthritis will really commonly comment on being stiff in the morning that improves with activity during the day. And really, stiffness is even more common than pain. On our patient's review of symptoms, he has chills, nausea, and vomiting. These are all non-specific symptoms, but also point to like a systemic cause. The left lateral chest pain is like pleuritic in nature. It makes me think that an inflammatory cause is more likely as opposed to an infectious cause like a pneumonia or something. So your hypothesis at this point, malignancy, non-infectious causes are probably less likely. You think of common things being common, but we still must consider them. Our first job will definitely be to make sure that he doesn't have an acute bacterial infection. Something for right now, your students may pick up on this as well, is that with COVID-19 circulating in the community, that is one of our must not miss diagnoses. And with this patient's age and his fever and GI symptoms with nausea and vomiting, really be worried about MISC or the multisystem inflammatory disease in children associated with COVID-19. So that's something to consider and you may want to bring up with your group. So here we have a nice flow chart to think about polyarticular arthralgia. Something that I wanted to make a distinction first is that arthralgia really just talking about pain in the joint, and that's not to be confused with arthritis, which is inflammation of the joint. When we think of inflammation, we think of redness and swelling, kind of signs of inflammation. So this flow chart is for polyarticular arthralgia, and the polyarticular is a really specific term. When you think about juvenile idiopathic arthritis, it's really divided up between two big categories. You have oligoarticular, which basically means 4 or less joints involved, and then polyarticular, which is 5 or more. So Keep in mind we're looking at a very specific subset of patients here. So as you move down the flowchart, first with non-inflammatory conditions, these are relatively uncommon in pediatrics, and each are kind of their own diagnosis of exclusion, kind of depending on the history and exam and other labs and findings. As you move towards the inflammatory, we really want to be sure that we address the possibilities of any kind of acute infection. If there is a septic arthritis or something similar, that could lead to long-term joint damage, and we really want to investigate that, and diagnose that really quickly. After we exclude the infectious, you can think about the post-infectious and then the inflammatory causes that we'll dive into more. Here's a nice flow chart that we can work with our students to think about fever, with each organ system having their own causes. It may not be the most effective for a bedside clinician, but it's good to get our students kind of thinking systematically when thinking about what could be causing their fever. One of the red herrings in this case so far we haven't quite addressed is that he was in Arizona with his family, bringing up all kinds of opportunities for insect bites or animal bites, and we'll cover more of that later. Other good considerations: strenuous exercise, thinking about rhabdomyolysis. Our patient has both muscle pain and joint pain, so muscle pain, muscle aches can easily be confused for arthralgia in pediatric patients. Sometimes it's really hard to get a really precise history, but the fever is a bit odd. There are some viral causes of rhabdomyolysis for us to consider. So another comment about his muscle and joints, you really want to be careful you're getting a really precise history in pediatric patients, and always want to focus in on are there any swollen, red, or hot joints, because that's actual evidence of arthritis that can direct our differential diagnosis. You want to get a full history, of course, and a nice review of systems, kind of focusing on headache, photophobia, neck stiffness. These would all be signs of meningitis. When you think about this patient's age and his travel history, some type of viral meningitis would probably be most likely to me, especially if he had all these systemic symptoms associated with headache and neck stiffness. So, review of systems. Previously, we mentioned there was really no signs of URI symptoms, but we want to be careful that we document any of those at this point. So what are the next steps? So in our case, we review the vital signs, exam, make sure he's not in shock, and then they recommend maybe giving 1 gram of acetaminophen or 600 that should be milligrams of ibuprofen orally, and maybe consider a bolus of IV fluids. A couple comments here. So while giving 1 gram of acetaminophen will likely not harm this patient, it could be a bit bigger of a dose than we commonly do in pediatrics. This could be a good opportunity to introduce the concept of weight-based dosing, something we deal with every day in pediatrics. Remember, acetaminophen is somewhere between 10 to 15 milligrams per kilo dose every 4 to 6 hours. Ibuprofen, on the other hand, is 10 milligrams per kilo every 6 to 8 hours, so that would be something to consider as well. But thinking about the isotonic fluid bolus, obviously giving some amount of IV fluids is not a bad idea if you're worried about volume depletion. Most children who are ill, who come to the ED, will have some reduced oral intake. This could be a good opportunity to review the signs of dehydration in a child. Think about dry mucous membranes, decreased urine output, tachycardia, and whatnot. But also remember that IV fluids are dosed according to weight as well. So we don't typically just hang a liter bag of fluids and let it run wide open. We would typically dose the IV fluid bolus, and that would be 20 mLs per kilo is a standard dose for an IV fluid bolus. Something also to focus in on, we always bolus isotonic fluids outside of rare, unique circumstances. So 0.9% saline or lactated ringers are most commonly used. So you get some subsequent additional history. They say at home, 2 weeks prior to the illness, the patient had several ticks crawling on him without a definite tick bite. So we know that kids who eventually develop tick-borne illnesses, a solid history of an actual tick bite is not common. So we would definitely need to consider tick-borne illnesses causing his symptoms at this point. His past medical history is mostly unremarkable. You see a comment about this tongue-tied condition that's explained below. that was actually clipped as an infant. Social history: lives at home with his mother and stepfather. No tobacco use. There is some passive smoke inhalation. No drug use. Recent travel to Arizona and California. He has a dog, an outdoor cat, and a rabbit. And this rabbit's a well-placed red herring because they're commonly tested sources of tularemia, which can be transmitted by tick bites, and your students may want to investigate that. Family history: there's a stroke in his father in his 40s, and some heart disease in multiple family members. So our patient's review of systems, kind of focusing in on abnormals here. He's got pain in his thighs, his calves, his ankles, wrists, and forearms, and lower back, but there's no skin rash, and that's a good point to keep in mind, because if the development of a skin rash would direct our differential diagnosis. So CNS: there's a mild to moderate headache with mild photophobia without change in mental status. So we're still keeping ideas open for some type of viral meningitis at this point. So kind of thinking back in on the pertinent findings, they say that this case is in the summer. So, interviral meningitis is something that's commonly diagnosed in the summer to fall in children who may have these kind of collection of nonspecific symptoms. It's something to consider. You also have to think about what type of bugs are in the Southwest United States. So we'll get to more later. So tongue-tied, remember that's ankyloglossia. It's like a short lingual frenulum that interferes with normal tongue movement. It's really common. We see it all the time in the newborn nursery. Most children do perfectly fine despite this. It's sometimes clipped by ENTs or oral surgeons if there's interference with feeding, but it's really on a case-by-case basis. So how has our differential diagnosis changed? We still have not quite ruled out, acute infectious causes, and that'll be the front line of what we do for this patient. It might be also worth mentioning COVID-19 and MISC, since everything that we're dealing with right now in our community. Outside of infectious causes, we really got to consider stuff like polymyositis and SLE and JIA, not JRA, Kawasaki disease, rheumatic fever, lymphoma, leukemia. So what's next? We're going to move on to our physical exam, kind of focusing on various findings that will direct our differential. So here's our exam. The well-developed nervous white male. He's moderately ill and flushed, mentating appropriately. He's febrile at 39.5. BP is normal. He's tachycardic at 129 beats per minute. Respiratory rate's 18. Oxygen saturation is 96% on room air. So kind of thinking about vital signs. Remember, normal vital signs are age-based. And it's something we deal with every day in pediatrics. As children reach puberty, most of their normal values will align with the adult values. And this is a pretty interesting aside here. So our children who are actually, pubertal age and older are actually suffer a higher risk of having a delayed diagnosis of something like sepsis and severe bacterial infections, because many of our algorithms are really pediatric and young patient based. So having a high heart rate here of 129, for many of our patients, this would be normal. So it's something we have to be really careful with in the pediatric emergency department. So kind of maybe having a student kind of read into age-based normal vital signs could be an interesting and a good activity. So moving on to the rest of his exam, HENT is mostly normal. There's no lymphadenopathy, maybe being somewhat reassuring that you're not dealing with like a leukemia lymphoma, no splenomegaly, no hepatomegaly. And moving on to his extremity exam, he's got diffuse tenderness and palpation to the feet, ankles, calves, thighs, and wrists and forearms. Range of motion is difficult to assess because of the pain, but there's no swelling, no warmth, no erythema of any joint. So we still have arthralgia, meaning pain in the joints. We don't have evidence of arthritis quite yet. No rashes, but he's flushed, and there's 2 small erythematous papules in the right antecubital fossa with some surrounding ecchymosis. So it's still kind of thinking about infectious causes. Did he get bitten by a tick or something that's causing this infection? The absence of a rash here is kind of reassuring against something like systemic JIA that we'll talk more about later. those children commonly will have like a pink colored rash. So we've talked about the pertinent findings so far, and we've even highlighted some of the negative findings. So what's the next steps? I think getting labs on this patient is a good idea. So CBC chemistries, ICAL, LDH urinalysis, urine culture, blood culture, specific antibody testing for Ehrlichia, Rocky Mountain spotted fever, and a chest x-ray. It's probably not a terrible idea to go ahead and get a CRP and an ESR to look for evidence of inflammation. And in keeping in mind our current context, we're so worried about missing something like MISC that an expanded initial workup might be considered here. Ferritin, coags, fibrinogen, and D-dimer, just kind of depending on the feel of the actual patient. So we have a look at his labs. Our patient, let's start off with leukocytosis, and actually has a neutrophil predominance with some immature forms and some relative lymphopenia. All of this suggests like an infectious versus an inflammatory condition, something for us to keep an eye on. Our patient has a normocytic anemia with a hemoglobin of 11.8 and a MCV of 83. We don't have a great reason for this 12-year-old boy to have anemia. It's really uncommon to have anemia in kind of a pubertal male. So that would be something for us to keep in mind. Chronic inflammation can be a cause of normal MCV anemia for a patient like this. A couple other non-specific findings here. So a low albumin of 3.3 it can be seen in children with systemic illness. With the subtle hyponatremia is something that we'll see in kids who are sick and would not be reassuring. Here we have a creatinine of 0.7, which is technically within normal limits. But keep in mind that creatinine is related to the amount of muscle mass our patients have. And even though it looks like it's within normal limits, depending on this patient's build, it might actually be elevated from his baseline. So keeping that in mind as well, that pediatric patients will have different normal values depending on their age and other conditions. Our patient has a mild elevation in ALT and a borderline elevation in AST. It's really non-specific. It's definitely not grossly elevated, but it's worth remembering. We have an LDH that's slightly elevated. It's a really non-specific sign for hyperinflammation. We sometimes will grab this. If it's significantly elevated, we might suggest a malignancy. So moving on to his urinalysis, some small ketones here are 15 milligrams per deciliter. That's likely secondary to decreased oral intake or the increased metabolic rate that accompanies a fever. So that would be not uncommon to find. A little bit of proteinuria here as well. This is also not uncommon for patients who are sick with like inflammatory conditions. We would want to closely follow this up. Lupus technically is in our differential at this time with a patient with fever and joint pain. If this eventual diagnosis were to be lupus and he were to have persistent proteinuria, that would be a really bad prognostic marker, and we'd want to carefully evaluate and monitor that. So you have your antibodies that are pending, your cultures are pending. Chest x-ray here, no pneumothorax, no pleural effusion or consolidation, heart appears normal, no free air to the diaphragm. Pulmonary structures are unremarkable, but there are hilar calcifications. And that is really uncommon in my experience in pediatrics. And that would be concerning. And I would think about malignancies and tuberculosis and histoplasmosis, but this would be a patient that really want a comprehensive evaluation. And we'd consider, a CT scan or something of that nature. So we talked about the positive findings in his labs, leukocytosis, the ketones in his urine. We mentioned that the anemia and getting a reticulocyte count can be really helpful for differentiating what the causes of the anemia. Little comment here about Rocky Mountain spotted fever. This patient didn't have a rash, and I really think of these patients with Rocky Mountain spotted fever having a petechial rash. It's probably not 100%, but it's probably worth mentioning, thinking about what fits for this patient. So next steps, determining that the patient doesn't have a likely life-threatening illness and is discharged with follow-up. He was started on empirically for Rocky Mountain spotted fever or ehrlichiosis with doxycycline. It's a good comment here that doxycycline is commonly not used in children under 8 years of age due to fear of dental staining. But a really commonly tested concept when there's concern for possible Rocky-Mountain spotted fever, doxycycline is provided regardless of age because it's the drug of choice and because of the high morbidity and mortality associated with Rocky-Mountain spotted fever. So what does our patient get? They get 2 liters of normal saline, ibuprofen, and acetaminophen. His temperature improved, but his other vital signs maybe not as much. His blood pressure seemingly softened a bit to 100/41 with kind of that diastolic hypotension. Heart rate is a little bit elevated at 92. Respiratory rate is 24. His pain improved. He was moving around better in the room, and he was subsequently discharged home with follow-up. Let's see, and he got continued on doxycycline and told to take acetaminophen and ibuprofen as needed. So it's interesting aside here. This could be a really typical example about how sepsis in pediatric patients can be missed. So this patient received maybe upwards of 40 mLs per kilo of isotonic fluid, but his mean arterial pressure with a little bit of arithmetic here is around 60. And his heart rate is technically elevated and his respiratory rate remains elevated. Despite his fever improving, we typically will see with fevers, as the fever gets more severe, the heart rate will be more elevated. And with him having these persistent vital sign abnormalities despite a fluid resuscitation, I'd be really worried about this patient actually having compensated shock, which would be really concerning for me. So I feel like it would be not common for us to discharge a patient home after receiving this level of IV fluid resuscitation without like a clear gastroenteritis causing the volume depletion. But it might be interesting aside to explore the case in New York where a child had a missed case of sepsis, and that led to a lot of the policy about sepsis and surviving sepsis campaign and whatnot. It might be an interesting activity for our students. So he returned to the family medicine clinic 4 days later. He still has recurrent fever, worsening muscle and joint pain, vomiting on awakening, which is kind of a concerning sign. We kind of associate that, at least I associate vomiting early in the morning, may be concerning for increased intracranial pressure, and it would definitely get my attention. Taking acetaminophen, ibuprofen sporadically. Pain is mostly in his thighs and ankles. So review of systems here, we mentioned the vomiting, no fatigue, HENT seems fine, and MSK, continued myalgia and ankle pain with movement. His exam is normotensive, slightly tachycardic, and afebrile. And then focusing in on abnormalities on his exam, he's got some medial muscular pain with internal rotation of the hips, but full range of motion in his hips, knees, and ankles. There's no rash again, but now there are 12 small pustules scattered on his back. So he has a little bit of changing in his rash. And he's got 3 similar lesions noted on his right anterior knee. Looking at his neurologic exam, his cranial nerves are intact, strength in upper extremities seems fine, but in the lower extremities maybe is somewhat weak due to pain. He has bilateral ankle clonus, which to me I would not expect this for this patient. Thinking of ankle clonus makes me think of like an upper motor neuron type disease here, and it's hard for me to wrap my mind around what this could possibly be. It definitely would be concerning, and I want to work this up further. He's got a wide base gait, secondary to pain. He's unable to bear weight on his ankles. So his blood cultures and urine cultures are no growth to date, and your antibody testing are pending. So what's our assessment? He has an acute febrile illness with arthralgias and maybe arthritis. Definitely has myalgias as well. Thinking about tick-borne diseases, of course. And then starting to consider more and more our non-infectious causes as this continues to progress. Still, we're not ready to commit to something like juvenile idiopathic arthritis without further evaluation. So this patient sent home on doxycycline. I'm going to follow a pediatric ID. Tylenol or acetaminophen and ibuprofen will be scheduled instead of PRN. So we got at the follow-up visit, we get a few more labs and another X-ray. Here we see a ESR, which is kind of like a inflammatory marker being elevated at 94. Will be very concerning. The CRP also at 25.7 is very, very high and out of the reference range. All those kind of pointing at these are non-specific inflammatory markers that can suggest either an infectious or ongoing inflammatory condition. The creatinine kinase was obtained most likely because of the myalgias, and with it being normal, that makes any kind of myositis much less likely. So a chest x-ray here is normal. They don't comment on those hilar lesions at this point. I thought that was a bit odd. All right, so 9 days after the illness onset, the patient's mother was called the clinic and complaining of uncontrollable pain and fever, so he was sent to the ED. So subjective of this ED visit, he has point tenderness in his ankles and thighs, along with myalgias and diffuse pain in his feet. He's unable to bear weight. He's got pain in his shoulders, arms, and neck, and multiple joint pains, moderate fatigue for the past 2 to 3 weeks now. This is ongoing. He's got photophobia, mild anorexia with a little bit of weight loss, and some brief periods of dyspnea. He's had intermittent fevers reaching 103 degrees Fahrenheit today, and he also has recent development of a raised rash with kind of pustules on his back that is known to be intermittent when febrile. Review systems, we talked about the intermittent fevers, the rash, and negative, no nausea or vomiting, no other preceding illnesses, no abdominal pain, no sore throat. So here we're actually starting to display many of the features that are a bit more specific for JIA. These patients, especially who have the subtype of systemic JIA, will have daily fevers, and it's not uncommon for their rash to actually worsen when they're febrile. So that's a really good point there to focus in on. Moving to the physical exam, he is febrile at 39.2, maybe a bit hypertensive. All the rest of the vital signs are, as we would expect, a little bit of tachycardia. Musculoskeletal exam, his moderate pain with external rotation of the hips, but full range of motion in his hips and knees. Left ankle is swollen and slightly erythematous, and the right ankle is as well. And this is actually our first evidence of arthritis, that being swelling and redness and evidence of inflammation of the joint. Skin exam, there's some small pustules on an erythematous base on his back, as well as some pink macular lesions on both ankles and shins. And this pink macular rash is kind of consistent with what we see in systemic JIA, especially when the patients are febrile. And our neurologic exam at this point is actually normal, and there's no comment on that clonus that we heard of previously. So your labs, your individual PCR testing is negative, rapid strep is negative, and your blood culture and actually got a peripheral blood smear, and those are both pending. So here's a look at the rash. I know it's not quite in focus here, but some take-home points. The classic JIA rash is described as an evanescent, kind of transient, salmon pink, macular rash that's more noticeable when the patient is febrile, and you can appreciate some of that here. So here are our labs from this visit. We have a continued leukocytosis with a neutrophil predominance with some immature forms and a relative lymphopenia. And this is worrisome, of course, for an ongoing infection versus an inflammation. Our patients also developed a thrombocytosis that we see with hyperinflammatory conditions, and then the continued same anemia. More of the same here. Albumin remains slightly low. The sodium remains slightly low. You see the creatinine actually settled down to 0.6 from last time. And then the ESR remains elevated at 86 and the CRP at 19, suggesting ongoing inflammation. They actually obtained an aldolase here, which is mildly elevated at 16.1, which is a non-specific marker for muscle breakdown. CK remains normal. So you have your problem list here, 9-day history of intermittent spiking fevers, myalgias, and arthralgias. The longer this actually goes on, the less likely an acute infection is the cause, and we start considering more and more like malignancies versus hyperinflammatory syndromes. History of the bite in Arizona or Colorado, tick exposure, some nausea and vomiting, synovitis in the bilateral ankles, pustules on the back and knee, with the pink macular eruption on the lower extremities when febrile. So in our lab abnormalities, we've commented on leukocytosis with increased neutrophils, the normocytic anemia, thrombocytosis, and the mildly elevated aldolase with normal CK. So what's our hypothesis? We're thinking tick-borne illnesses are probably becoming less and less likely. We still have some considerations as we move towards more of an inflammatory causes. So what do we do next? Submitted for observation. Doxycycline was discontinued. He was started on IV medications, IV ketorolac, which is an IV NSAID, and then oral acetaminophen for pain and fever. An additional lab workout with an ANA, a rheumatoid factor, to assess for some evidence of JIA, vasculitis, and lupus, and then additional infectious etiologies need to be ruled in and ruled out. So that concludes part 1. So coming back to part 2, this is a good overview of what we've said so far. So we're on the pediatric inpatient service for fever, for observation and kind of further determination of what's going on with him. Another summary here: doxycycline was discontinued, starting on IV medications, IV ketorolac, and oral acetaminophen. So we have more labs to look at. So first, notice the reticulocyte count at 1.2%. While being within the reference range, because of his anemia, we'd actually expect a higher reticulocyte count. So it's actually inappropriately normal. And this kind of suggests like this anemia of chronic inflammation or iron-restricted hematopoiesis that we see with chronic inflammatory conditions. So serum iron studies, the iron level was normal, the TIBC was normal, or anything was a little bit low, and then the ferritin was markedly elevated. So ferritin, we sometimes think of being like a marker of your iron stores, but it's also an acute phase reactant and will be elevated when there is inflammation. Another aside is in patients with systemic JIA, an exceedingly high ferritin level is associated with a condition called macrophage activation syndrome, which is like an ongoing hyperinflammatory disease that's life-threatening and can be acutely fatal for these children. Other markers of inflammation, the ESR remains elevated. The CRP remains elevated as well. Aldolase is approaching normal, and the rheumatoid factor is undetectable, and that's most commonly what we see even in patients with JIA. They will not have a positive rheumatoid factor. So results from the blood smear: normochromic, normocytic RBCs, the leukocytosis, and most of that was within normal limits. So what treatments are best for J? So like an NSAID will help with the pain, help with the fever, and the ongoing inflammation. And naproxen, as soon as we're off of Toradol, naproxen is usually preferred for oral NSAIDs over ibuprofen by most of our rheumatologists. So looking at his ANA studies, it's positive technically with a 1 to 80 titer, which isn't the most significant. Many of our patients will have much higher ANA titers, and then all of these individual antibodies are normal. And here's an opportunity for your students to kind of think about all of these different lab tests and kind of what they're looking for. It might be a good thing to have them do. So our hospital course, he continues to feel well. I'm going to switch to oral acetaminophen and naproxen. He did continue to have fevers every 1 to 2 days, but he was not as symptomatic when febrile. His families were anxious for discharge because he's been feeling better. They're also getting increasingly frustrated by the fact that he doesn't quite have a formal diagnosis despite all of the labs and imaging tests. And it was decided that not much more workup could be done as an inpatient, so he's discharged home with close follow-up. Even had this tagged white blood cell scan looking for an infection that was eventually negative. Something to kind of focus in on here is that like a level of frustration in helping these families with children with these diagnoses of exclusion, kind of in air quotes. it can be really frustrating. And good communication with our families and kind of setting expectations for each individual study is very important. And I think maybe diving into some of the perspective of our families would be a good discussion to have with our students, because this is definitely commonly encountered. So for our patient, it was explained to them that JIA was most likely, but like we said, it's a diagnosis of exclusion. All the lab tests that were already done. A chest CT was set up to evaluate the nodule seen earlier in our case. He was sent to HEMONC for the evaluation of the night sweats, to get a bone marrow biopsy, which is commonly done for these patients. You don't want to miss a malignancy and diagnose someone with JIA. One thought is that a common treatment for arthritis would be corticosteroids. And if we were to give corticosteroid to a patient with eventual leukemia, that could actually upstage their leukemia, because we would essentially be exposing those cancer cells to one of the main types of chemotherapy. So that would be a really big deal. So another comment about how you think patients and their families are affected when a diagnosis of exclusion is made. In very short, it's very, very frustrating, and it relies on the medical team, being very, very clear in the expectations and communication. It's really hard. It's easier said than done. So you get your CT report with some scattered mesenteric lymph nodes, but otherwise normal. He got his bone marrow biopsy for flow cytometry, cytogenetics histology, and whatnot. And it was mostly normal. There is this comment here about the hematopathologist noted a megaloblastic myeloid changes, which can be subtle. You can refer to that. And here's that pathology report. So Jay followed with his pediatrician 1 week later and continued to be afebrile without pain or rash. The resident on the team asked about starting immunotherapy like tocilizumab that we've learned more and more about with COVID-19 and Intercept, and they deferred to rheumatology. So he saw the pediatric rheumatologist, who confirmed that it was most likely JIA. Remember, JIA is being that diagnosis of exclusion. Most commonly, we want to see about 6 weeks of symptoms before we're comfortable making that diagnosis, and after other pathologies have been reasonably excluded. Our patient was asymptomatic and was weaned off all of his medications and remained pain-free and afebrile for the past 5 months. Continues to see his pediatrician regularly. So that concludes our case. Maybe a couple more comments about JIA before we wrap up. So juvenile idiopathic arthritis used to be referred to as juvenile rheumatic arthritis, or JRA, or juvenile rheumatoid arthritis, I should say. That nomenclature has been mostly abandoned, and now JIA is the preferred term. So chronic joint inflammation, unknown etiology, and has to manifest before 16 years of age. So there's actually several subtypes that we've kind of suggested thus far. Systemic JIA is the most severe and most concerning. Those patients can rapidly progress and develop a syndrome called macrophage activation syndrome that can be acutely fatal, and is very, very concerning. Other types, you have oligoarticular and polyarticular. Here you see pauciarticular, and that terminology has now been displaced in favor of oligoarticular. So the difference really is how many joints are involved in the first 6 months. If there are 4 or fewer joints involved in the first 6 months, we call that oligoarticular. That portends a better prognosis. And polyarticular means at least 5 are involved in the first 6 months. So thinking about what is most commonly seen for JIA, morning stiffness is very specific for inflammatory causes. We'd always look for that. It can be a limp in a young child without a history of trauma, also be something considered. Here's another comment about requiring at least 6 weeks of symptoms before you're comfortable making this diagnosis in a patient less than 16 years of age. And uveitis is also commonly seen, or seen enough that we should get regular screening exams by ophthalmology. So just a couple of comments about treatment before we wrap things up. So It's a multimodal approach. NSAIDs are typically first lines, with naproxen being preferred. If there are relatively few number of joints, intra-articular glucocorticoids can be very helpful because of their limited side effects, because it's actually intra-articular. If you're having symptoms that are refractive to your initial therapy, you start thinking about disease-modifying agents, like methotrexate is probably the go-to. After that, you're really considering different biologics. You have a steep increase in cost and consideration for different side effects. So the prognosis is somewhat variable. We mentioned that in general speaking, the fewer the number of joints that are involved, the better the prognosis is. But as you increase up to something like systemic JIA, your risk tolerance for things like fevers become much, much lower, because they are at risk for developing this macrophage activation syndrome that could be acutely fatal. So they finish up here with just the mechanism of actions of tocilizumab and adalimumab, and all of these different types of monoclonal antibodies that we've heard more and more about with COVID. So maybe having a student review all those different types of antibodies could be helpful. The anti-IL-1 receptor, anakinra, is actually used quite commonly for patients with systemic JIA. It might be something else for them to consider. So anyway, that pretty much wraps it up. Hope you enjoyed this and thought it was helpful. Please feel free to give me any feedback. And thanks again, Dan and Nicole, for this opportunity. Have a good week.